colleagues. In the process of evolution, the introduction of fat was crucial both to plants and animals. Well, one of the side effects of fat is, of course, it gets stored and people get obese. And only this morning I heard on the radio obstructive sleep apnea syndromes in Belgium is rising, it skyrockets. And this has implications also for us anesthesiologists. How to dose our drugs, which drugs to choose. And our first speaker on this topic is Professor Harry Lemmens from Stanford University. He was trained in the Netherlands and is working in Stanford, did a lot of research on pharmacokinetics and pharmacodynamics, and in particularly on the opioid alfentanyl. So Harry, I think you're a perfect person to give us, to illuminate us on this topic. Harry?
Thank you for inviting me. I was born and raised in the Netherlands, and 50 meters from the Belgian border. So it's always a pleasure to be in Belgium. And in my younger years, I spent a lot of time in Belgium. The beer was better, and the cafes didn't have a closing time. So this is the title Jan gave me. So 30 years ago, we didn't have the problem of leptin resistance. Leptin is a hormone, or some call it a cytokine, that is being produced by fat cells. It works on the hypothalamus, and then it depresses hunger, it reduces food intake, it increases metabolism, and it decreases your body weight. So if you grow fatter, more leptin is being produced, and that should bring you back to your baseline weight. Unfortunately, that doesn't work anymore in many people. And now you're dealing with an obesity epidemic that is ever and ever increasing. And on average, people are now 10 kilos heavier than 20 years ago. So these are the latest data from the World Health Organization. So they show the prevalence of a BMI greater than 25. And in the darkest areas, the prevalence is more than 60%. So if you go to the WHO website, you can look the prevalence of obesity and overweight up by country. And I indicated a couple of them. So you see Vietnam is the skinniest country. The prevalence of a BMI greater than 25 is less than 20%. So Belgium is right there. And then in the US, normal weight people are a minority. So 1/3 is underweight, normal weight. In the US, that is underweight. And then 1/3 is overweight, and the other 1/3 is obese. So obesity is associated with a lot of comorbidities. Type 2 diabetes, heart diseases, obstructive sleep apnea, pulmonary abnormalities, NASH, which is the fatty liver syndrome, cerebrovascular diseases, the metabolic syndrome, GI abnormalities, osteoarthritis, cancer, and also psychosocial problems. So when you do PK/PD studies in the obese, it's basically impossible to take all those comorbidities into account and account for their effect. So the question is, when total body weight dosing is wrong, what is right? And sometimes total body weight dosing is right. So these are 3 groups of morbidly obese patients who received succinylcholine for tracheal intubation. So group 1, which is the green one, received 1 milligram per kilogram total body weight. Oh, sorry, it's group 3, we see here. Then group 2, which is in the middle, 1 milligram per kilogram lean body weight. And then group 1, 1 milligram per kilogram ideal body weight. So you see that the total body weight group reliably gets to 100% twitch depression, which will give you excellent intubation conditions. If you get less, you don't get reliably to 100% twitch depression, and your intubation conditions might be poor. So the reason for that total body weight dosing is that pseudocholinesterase activity increases with increasing BMI. And this was actually published in the 80s already. So this is work from the Leiden group, and they looked at morphine concentrations after 10 milligram IV bolus dose, and they looked in obese and lean patients. And after the 10 milligram IV, they didn't find a difference in plasma concentration of morphine between the obese and the lean. But the concentration of the metabolites, M3G and M6G, was higher in the obese, which is perhaps due to their fatty liver disease. So they did the pharmacokinetics, and they did some simulations for different weights, ranging between 56 and 253 kilos. On the upper panel, you see the simulations for the 10 milligram bolus dose. And you see on the left panel that morphine concentrations really are not that different between a person that weighs 56 kilo and a person that weighs 250 kilo. The metabolites actually are higher. And in the lower panel, you see a simulation of an morphine infusion. And again, not much difference between morphine concentrations, but the metabolites actually get to pretty high levels. So a morphine infusion or repeated bolus dosing of morphine in the obese might not be the best choice. So this is work from Cortines and Strauss, and they looked at the propofol pharmacokinetics, and they found that total body weight allometric scaling for volumes and distribution clearances, and also elimination clearance could be characterized by an allometric model scaled to total body weight. And this, of course, is important for TCI pumps, and will pretty accurately predict the plasma concentration. So the Leiden group almost did an identical study, and they found that total body weight allometric scaling was significant for clearance, but not for any of the other parameters. So in here you see their individual clearance values plotted against total body weight, BMI, ideal body weight, and lean body weight. And you see there's a nice linear relationship with total body weight, so that's why allometric scaling works so nicely. So none of these studies looked at the front-end kinetics, and the front-end kinetics are important to determine the bolus dose, the induction dose of an induction agent. So the front-end kinetics are drug distribution and dilution in the first minutes after administration. Cardiac output has a significant effect on the front-end kinetics. For example, a decreased cardiac output increases the fraction of drug distributed to the brain. It reduces the rate of redistribution and will result in higher concentrations and a reduced dose requirement. That was found out the hard way during the Spanish Civil War in the late 30s, and after the attack on Pearl Harbor, then large doses of thiopentol were used to anesthetize hypovolemic trauma victims. And under those circumstances, thiopentol very quickly got the name of being an ideal euthanizing agent. So Stanzi and Wada, almost 25 years ago, looked at the effect of cardiac output on thiopentol peak concentrations after a 250 milligram dose. So on the left, you see the effect of cardiac output. So on the lower the cardiac output, the higher the peak concentration. The higher the cardiac output, the lower the peak concentration. Obese patients also have a lower peak concentration. Males have a lower peak concentration. And older people have a lower peak concentration. So these simulations are based on a pure physiological model that was derived from rats and then scaled up to humans and validated in humans. So this is an MRI image of a morbidly obese person. You see the layers of fat, you see the fat in the abdomen, you see a huge liver that sticks into the chest. The heart is enlarged. So the body composition of this person is changed, and of course his body size is hugely increased also. And what always is striking when you look at these pictures. That's how small the lung volume is. So the increase in body size and the change in body composition will have an effect on cardiac output, tissue perfusion, drug distribution, and drug clearance. So this is a schematic of a normal frame, 160 centimeter tall male who is very leptin resistant and increases his body weight from 17, I would say his BMI from 17 all the way up to 70. So you see that his total body weight increases from 52 to more than 200 kilos. His fat weight increases from a couple kilos to more than 100 kilos. And his lean body weight increases also from 50 to almost 80 kilos. So your lean body weight increases because you need to carry all that extra weight around. So what you see here is that the ratio of fat weight to lean weight is different at different BMIs. And also fat is differently perfused at different BMIs. At low BMIs, fat is pretty well perfused, and at high BMIs, fat is very poorly perfused. So that different lean fat ratio and the differences in fat perfusion make a description of the distribution of drugs difficult. That's the reason why you see so much discrepancy in PK studies in the obese. So the increased tissue mass needs to be perfused, so the blood volume will increase. And you see that same nonlinear increase of blood volume is basically almost parallel to the increase in lean body weight that you see here, a little different scale. So the total blood volume increases, but on a per kilo basis, the total blood volume actually decreases. So somebody who has a BMI of 22 has a blood volume of 70 cc's per kilo. Somebody who has a BMI of 60 has a blood volume of about 40 cc's per kilogram total body weight. So that's something to think about when you have a morbidly obese patient that is losing blood. Cardiac output also increases from about 4 at a BMI of 20 to higher than 6 at BMIs greater than 40. So, and again, nonlinear increase. So this was a study that was published in 2001, and it basically shows that cardiac output and lean body weight are highly correlated, which makes sense. You know, when you increase your lean body weight, you need to perfuse it. So this is a study that was done by Grande, and he looked at the propofol dose requirement for loss of consciousness, which you see on the y-axis, and cardiac output. The cardiac output was measured non-invasively by bioimpedance cardiography, which is not the most accurate method, but you still see a linear correlation. So when Grande in that study studied 30 lean patients, and he gave them an infusion of 100 milligrams per kilogram total body weight until they lost consciousness. And then he studied 60 morbidly obese patients, and he randomized them to 100 milligram per kilogram total body weight per hour, and 100 milligram per kilogram lean body weight per hour. So, and these are the results. So, and you see that the morbidly obese patients that were dosed according to their lean body weight required the same dose as the lean patients that were dosed according to their total body weight. So lean body weight dosing in the obese is similar to total body weight dosing in the lean, at least for propofol-induced loss of consciousness. And you know, with this infusion rate, the time to loss of consciousness was about 1.5 minutes. And here you see the correlation between total body weight and dose in the leans, and total body weight and lean body weight and dose in the morbidly obese. And you see there's a pretty high correlation. The R squared is 0.74, which means that 74% of the variability in dose requirement can be explained by lean body weight. So this is work that's being done by Egan, So he first determined the pharmacokinetics of remifentanil in lean and obese patients. And then he used those pharmacokinetic parameters to simulate lean and total body weight dosing in a lean patient and in an obese patient. So in the middle you see the lean patient. There's not much difference in concentration between total body weight and lean body weight dosing, because total body weight and lean body weight in a lean person is almost the same. If you dose the obese on lean body weight, you get concentrations in the same range as the lean patient. If you dose the obese based on his total body weight, you get pretty high concentrations. So the lower curves is what you typically need for abdominal surgery, and the obese patient based on total body weight, has pretty high concentrations, and at these concentrations you're going to see significant side effects like hypertension and bradycardia. The inhalational anesthetics. So here you see the uptake of several inhalational anesthetics. The uptake is on the y-axis, FD over FA. The anesthesia time is on the x-axis. And you see that the uptake is higher for lipophilic anesthetics and also at the beginning of administration. I think everybody in this audience knows that. So this is a different way of looking at it. So it goes to the vessel-rich group, it goes to the muscle group, and it will distribute in the fat group. So isophorane is pretty lipophilic, so should we avoid isophorane in the obese? That was the story when sevoflurane came on the market. So if you look at the fat perfusion in an obese and in a lean person, and you see the fat perfusion is significantly decreased in somebody who has a BMI of 39. So and then we did a study, I think that was when Jan was at Stanford also. And we looked at the uptake of isophorane and desflurane in obese and non-obese patients. So the uptake is expressed two different ways, FD over FA, which are the upper curves, or FI over FA, which are the lower curves. So the solid circles are obese patients, and the open circles are the non-obese patients. And you see that for isophorane, there's a little bit difference, especially at the beginning, the little stars, but you can say that those are clinically insignificant. And for desflurane, there's basically no difference at all. So when you look at wake-up times in that same study, you see there was no significant difference between obese and non-obese that got isophorane, and also no significant difference between the ones that got desflurane. Of course, the ones that got desflurane wake up 3 minutes faster. So how do we explain that? In the obese, fat receives a lower percentage of the cardiac output, 2% versus 5% in the lean. And then the time constants for equilibration of inhalational anesthetics with fat are very long. So for isophorane, it's more than 2,000 minutes. And then also, during anesthetics of 2 to 4 hours, the partial pressure of anesthetic in the fat remains below the neck awake. Okay, a little bit about muscle relaxants. Rocuronium, 1.2 milligram per kilogram, ideal body weight, should provide you excellent or good intubating conditions after 60 seconds. This is atracurium based on ideal body weight, 0.5 milligram per kilogram in the upper panel, and 1 milligram per kilogram total body weight in morbidly obese patients. And you see the total body weight dosing results in a prolonged recovery and a little bit unpredictable recovery. The same was basically shown for vecuronium. So after anesthetizing a morbidly obese patient, it's very important to make sure he recovers fast. So if you have somebody who doesn't wake up and it takes longer than 20 minutes, you see a 4 to 5-fold increase in respiratory complications. And on the same tone, 20% of unexpected ICU admissions are because of anesthetic complications, and respiratory complications are the major part of that. So, and this is after bariatric surgery, and the bariatric surgery patient is basically a relatively healthy obese patient. Okay, the reversal agents. Fortunately, we have finally Succinylcholine in the United States. So, and I don't think it's completely clear which is the best dose for Succinylcholine in the morbidly obese. The package insert in the States states that you need to base it according to total body weight. I personally don't think it makes any sense, so I think lean body weight is the thing to dose it. But there are no good studies. Okay, so how do we do it? Unfortunately, there is no accurate non-invasive measure of cardiac output or a good way to measure accurately lean body weight. So what you can do is you can, take the ideal body weight and then add 20 to 30%. I think it's important to titrate opiates to effect and start with lean body weight. For the really morbidly obese patient who has a BMI greater than 50, I don't think you should use long-acting opiates like Dilaudid or morphine. For TCI maintenance dosing, allometric scaling to total body weight for propofol is important. So the effect of obesity on inhalational anesthetics is minimal and moderate doses are used. Dose succinylcholine based on total body weight. Non-depolarizers, ideal body weight or lean body weight. And keep in mind that studies are done in bariatric patients. And they definitely do not apply to the morbidly obese with significant comorbidities. So thank you. I'm open to critique and questions. Yeah.